Good morning, everyone, and welcome to this first home health training since the pandemic shut things down in March 2020. There have been a few changes since then, and this presentation focuses on the not too distant coming changes, including updates to OASIS. As you may or may not know by now, we'll be transitioning to OASIS-E1 from OASIS-E. And with time permitting, I will also discuss care plans since a lot of people seem to need a refresher on this topic, or maybe they've never received detailed training. I'm Carol Eastberg, the State OASIS Education Coordinator. I'm also a health facilities inspector and previously did on-site state licensure, federal recertification surveys, and complaint investigations at several facility types, including home health, hospice, and long-term care. Just so you know, this is being recorded. Before we get into today's session, I want to let you know about a training by the Texas OECs on Section M, Skin Conditions. Go to the registration link on this slide to sign up for the August 29th session. It's from 7:30 a.m. to 10 a.m. Pacific time. Even though we're not in Texas, y'all are invited and welcome to attend. Just remember to check into the related requirement of the Nevada Administrative Code if they mention anything related to specific state requirements. Most states have different requirements, so be sure and check Nevada's. This is our agenda for today's training. I apologize again that we got started late. As I explained, I've been having major computer issues. So the goal is to wrap it up by 11. Be sure to stay on after you submit. Well, that's a whole other thing. I haven't been able to prepare the post-test and evaluation. So depending on how that goes, I'll be giving you further instructions later. So as I mentioned, this session is being recorded, and I will let you know as soon as it's available. And as I mentioned earlier, today is probably part one of a two-part series. So as soon as I have the date for the second part, I will also let you know that. Hopefully you all have received the handouts by now. If you can raise your hand, I will unmute you and let me know yes or no if you have or haven't received it, or you can put it in the chat. Do you all still hear a echo? Okay, thank you, Ashley. I see that you can see the screen. Thank you. Is the sound okay? I see lots of hands raised, so I guess everything is good. All right, I'm going to continue on. Okay, so our objectives for this session are that when we finish this session, you all will be aware of the changes coming to OASIS-E item sets on January 1st of 2025. You'll be able to comprehend how to properly code specific new and old items, and you will understand how to formulate and follow a patient-centered POC. Here's the disclaimer. CMS let me start over. The state OASIS education coordinators have not received any training from CMS since 2018. And in 2023, they stopped supporting us altogether. However, there is a wealth of information on the CMS website, and it's fairly simple to access. Just go to cms.gov and type in the search field what it is you're looking for. And as you know, information changes frequently, so be sure to plug into the various resources available so you can stay up to date on all things OASIS and home health. And you always need to go by what CMS says. There are lots of links in the resources in the back of your handout today, so feel free to go to those sites and check it out. This slide shows the progression of version revisions OASIS has undergone in the past 25 years since its debut in 1999. Major changes were made in 2023 due to the need to standardize the items across all post-acute care settings, which I began talking about back in 2015. OASIS-E1 is the result of minor changes to the OASIS-E instrument and guidance manual, reflecting proposals finalized in the calendar year 2024 of the Home Health Final Rule. Let me just stop here for a moment and say, if you have not received the handout, check your spam or trash box. It may have gone in there accidentally, so check there, please. You can see the changes as we transition from OASIS-E to OASIS-E1 beginning on page 259 of the manual, table D2. On a side note, I was introduced to and fell in love with home health in mid-1990, 8 years before CMS came out with OASIS. And we were just in OASIS-B when I left home health in 2005. So it's been around a while, and I've been around a while. These are the minor changes effective January 1, 2025. 2 items in section A, MU110 and MU2200, have been removed from the start of care and the resumption of care item sets as they no longer are used to calculate payment or quality measures. The instructions for the PHQ 2 to 9 in section D150 were revised. The GG130 self-care and GG170 mobility items have been removed from the discharge goals due to the removal of that quality measure. The skip pattern was revised for M102 in section M related to the date the SOC or ROC are ordered. And then there's a new, oops, back up. That wasn't supposed to happen. A new item, O350, patient's COVID vaccination is up to date, is associated with the new COVID vaccine quality measure to coincide with the new home health quality reporting program measure is being added. Patient's COVID-19 vaccination is up to date. So the draft version, I haven't seen a final version yet, but the draft version of the guidance manual directs the assessing clinician to review the medical record or documentation and/or interview the patient, family, or other caregiver or other healthcare providers to determine whether the patient is up to date with the COVID-19 vaccine, including boosters. It also states that vaccination status may be determined based on information from any available source. I strongly encourage you to have your intake coordinator add this to the list of items they request from the referral source, whether it's the physician's office, the hospital, rehab, wherever the referral comes from. And according to the manual, if the patient is not up to date and the agency has the vaccine available, the clinician is to offer the patient if they would like to receive the COVID-19 injection. The manual further directs providers to reference the Centers for Disease Control and Prevention, CDC, website to determine whether the patient is up to date, and states agencies should already be familiar with the CDC's vaccination website. I did some research and ran into a block wall. So I contacted the Nevada vaccine people and just received a response yesterday. So in his email, he explained how to access the information. There's some consent and privacy forms that agencies will need to fill out. And I will forward that information to all home health agencies in the next couple of days as time allows. All right, the OASIS data collection time points have not changed. This is just here for your quick reference with a couple added notes by yours truly. When the regulation says calendar days as opposed to business days, this includes Saturday and Sunday. The start of care or SOC day is day 0 for the purpose of counting. So 5 days from that day, no matter which day of the week, 5 calendar days later, the OASIS is required to be completed. And if it's not, you're out of compliance with the federal regulations. So for example, for a start of care that occurs on a Friday, you have until the following Wednesday, the 5th calendar day, to collect and enter all information into the OASIS. If more than one discipline, let's say an RN and a therapist and maybe a social worker, all 3 are on the case, they need to collaborate with one another, and the RN must complete the OASIS by the end of the 5th calendar day. Do you have to take 5 full days to collect the OASIS data? No, you do not. That is how much time CMS allows so that if multiple disciplines are required, they can all get in and do their respective assessments, collaborate, and ensure the OASIS is accurate and complete. If the case only requires skilled nursing, the RN should be able to complete the OASIS assessment and submit it within 2 days at the most. And of course, your agency should also have a policy regarding that time frame when the documentation is to be submitted. For recertifications, remember that the required window is during the last 5 days of the current cert period. You will get an error message on the final validation report if you complete the recert even 1 day early or 1 day late. Back when I was doing this, we had a Cardex type form that we plotted the cert periods out on and had to manually figure this stuff out. Nowadays, with your ever-evolving software programs, there is no reason or valid excuse to not know exactly when that 5-day window is. Also, in case you are planning to do a recert and discover that a resumption of care is also needed, patient was just discharged on day 2 of the 5-day window, you should do a resumption of care instead of a recertification. And you can find those directions at the top of page 31 in the manual. Now let's talk about the requirements for submitting or transmitting OASIS to CMS. Ever since OASIS was first introduced, agencies have always had 30 days from the Moon 90 or the completion date to transmit OASIS, and this is not changing. Per CMS, that means within 30 days of the Moon 90 or the assessment completion date. When I talk to people about it, I call it the Moon 90 because it's just easier to say. So Moon 90, assessment completion date, those are the same thing. Unfortunately, CMS does not specify if these are business or calendar days, but I can confirm from looking at the reports they are calendar days, which means the Moon 90 date is day 0, and you count 30 days from that date, which is the date by which the OASIS must be transmitted to be considered on time. Do you need to wait until the 30th day? Absolutely not. The 30 days are there to give staff members time to review for quality assurance, to ensure the beneficiary's information is entered correctly and that it matches what's in the system, confirm the diagnoses or query the physician for the same, enter the diagnosis codes, make any necessary corrections, use the information to create the plan of care, etc. Should you wait until the 30th day to transmit? Definitely not. What if your system goes down on that day, or the CMS system has technical difficulties? Yes, the hard deadline is 30 days. The goal should be to complete all steps necessary to ensure accuracy and quality, and then transmit as soon as that has been accomplished. Something else I need to mention here is that each agency needs to have at least 2 staff with their own individual credentials who can access iKeys to transmit OASIS and review the final validation reports to confirm the transmission went through, and also read them for any errors. You might get a fatal error or just a warning, but you need to be looking at the final validation reports to get that information and then proceed accordingly. Don't be one of those agencies that submits late and when contacted tells me the person who normally does OASIS transmissions is out of the country for a month. No, at least 2 people should have access and be able to do this task. The takeaway for this topic, it is imperative that OASIS be submitted timely. In fact, earlier this year, CMS sent this directive to state survey agency and accrediting organization surveyors to cite you at Tag G372 for just one OASIS transmitted late during the previous year. If the survey team identifies a pattern of late transmissions, the scope and severity of the citation will be set accordingly. So here's a side note for those of you who are not aware. Every 3 months, I pull the error summary report, which shows the total number of OASIS that were submitted and how many were late during the previous quarter. And I do this for each home health agency in Nevada. And then I call or email the home health agency's administrator and I point out how many were late and I ask what is causing the lateness, and I request their plan for how they will correct the situation. I also provide a report to the state survey team prior to their entrance for your recertification surveys, those that are under state authority and not contracted with an accrediting organization like ACHC, CHAPS, or Joint Commission. But they are also going to be looking for this scenario. So even if you're deemed or accredited to be deemed, they will be looking at this. If you are one of the many agencies that continuously submits late OASIS, you may have already received a letter from CMS regarding the consequences, which may include a decrease in the amount of money that you receive from CMS. Some of you that I've talked to, have already experienced this. Also, and this is equally, if not more important, timely transmission of OASIS is a condition of assessment. When you signed on to get payment of federal dollars from CMS, you agreed to follow the conditions of participation. So that's one of them. And as the OEC, even though I do not get into anything related to claims or payment, I can tell you that under the patient-driven grouping model, or PDGM, matching a claim to the OASIS assessment is required to process each home health claim. So if you submit a claim to get paid and they don't have an OASIS assessment yet, you're not going to get paid. There's an order to which things have to be done. All right, let's switch to some other important information about OASIS. Since each patient and everything about them and their situation is different, it is not possible to imagine all the various potential scenarios that might present. So CMS has created these general rules, also known as conventions, as basic guidance or guardrails, if you will. While following these rules, the assessor must utilize their clinical knowledge and professional judgment, along with the collaboration of an interdisciplinary team as applicable, to produce an accurate and complete assessment. The first rule is to understand the time frame, also known as the look-back period, that's under consideration for each item. Report what is true on the day of assessment unless a different time period has been indicated in the item or the related guidance. Day of assessment is defined as the 24 hours immediately preceding the home visit up to and including the time spent in the home by the clinician conducting the initial assessment. So whatever is true from the time the assessor leaves the house to the 24 hours, including the 24 hours previous to that, that's what the look back period is, unless it's is specified elsewhere. Usually it'll say right there in the item that you're looking at so that you don't have to be going back and forth and looking to the guidance manual. But if you have a question about it, please look at the manual. For an episode to be considered a quality episode for the CMS quality reporting program, there must be a beginning and an end. Page 274 in the manual has the specific details for what qualifies as a quality episode, and I'll be getting into that a little bit in more detail in a minute. Let's see. 3, if the patient's ability or status varies on the day of the assessment, document what was observed greater than 50% of the look-back period, again, unless the item specifies a different time frame. Minimize the use of not applicable and unknown responses as much as possible. Between the physician's orders, discharge orders from the previous setting, the patient and or their representative, you should be able to find an answer. Social Security, Medicare beneficiary identification or Medicaid numbers, payment source, inpatient discharge date, emergency room visits, reason for the same, prior functioning, UTI in the last 14 days, bowel incontinence and frequency, etc. Of course, if an item definitely does not apply, then not applicable is the appropriate response. Some items do allow for a dash response. This indicates there is no information available. Do not use this dash simply because the information is not right at your fingertips. Do some research and see if you can find the answer. If there truly is no information available, you may use the dash, but note that CMS expects the dash use to be a rare occurrence. Number 6, documentation of a patient's current status is based on the observation of their condition and their ability at the time of the assessment. There should be no referring back to prior assessments or documentation of status from a prior care setting. Several process items require review of documentation of care that occurred at the time of or at any time since the most recent start of care or resumption assessment. And these instructions are included in item guidance for those relevant OASIS items. Assessment strategies for completing all OASIS items include observation, interview, collaboration with other agency staff, and other relevant strategies unless otherwise noted in the guidance. For example, it is acceptable to review the hospital discharge summary for information on a patient's episodes of confusion or to interview the caregiver regarding the patient's incontinence. However, when assessing physiologic or functional health status, direct observation is the preferred method. And the last one on this list, number 8, when an OASIS item refers to assistance, it means assistance from another person. And assistance is not limited to physical contact. It may include verbal cues and or supervision. It might be standby or contact guard assist, where they're just kind of have their hands there ready to catch them so they don't fall if it looks like they're going to. Number 9 on this list of 16 is clinicians must complete OASIS items accurately and comprehensively while adhering to the skip patterns. And you'll see that in the items, it'll tell you if the answer is whatever, skip to, and then it'll give you the next item to go to. So make sure you follow the skip patterns. Make sure you understand the definitions of words as used in the OASIS, and that can all be found in the manual. Always stay current with evolving CMS OASIS guidance via the updates to the guidance manual, posted Q&A documents, announcements that I might send you, bulletins, technical bulletins, things of that nature. 13, the comprehensive assessment, which is considered part of the patient's entire legal home health agency clinical record, includes all OASIS items. Remember, if you end up going to court for some reason, everything that you documented can and will be used against you if that's the case. And if it wasn't documented, then in nursing, we say it was not done. So make sure you document everything accurately. While only the assessing clinician is responsible for accurately completing and signing a comprehensive assessment, they may now collaborate to collect data for all OASIS items if agency policy allows. And CMS allows this, so your agency policy needs to reflect that. It's a change that came about, I don't know, in 2021, I believe. Collaboration may consider information from others, such as the patient, caregivers, and other healthcare personnel, including the physician, the pharmacist, and any other agency staff who have had direct contact with the patient or have some other means of getting information to contribute to the OASIS data collection. When collaboration is utilized, the Moon 90 date assessment completed is the last date that information used to complete the comprehensive assessment and determine OASIS coding was gathered by the assessing clinician, and documentation of the specific information and responses was completed. When used, collaboration must occur within the assessment timeframe and be consistent with data collection guidance. Any exception to this general convention concerning collaboration is identified in item-specific guidance in the manual. The use of the term specifically means the scoring of the item should be limited to only the circumstance indicated in that item. The use of, for example, means the clinician may consider other relevant circumstances or attributes when scoring the item. Allowed practitioners include, in addition to medical doctors, podiatrists, and nurse practitioners or advanced nurse practitioners, clinical nurse specialists, and physician assistants or PAs. All now have the ability to certify eligibility and provide orders for home health services where not prohibited by state law. Nevada allows it effective 12/29/22. Accordingly, when coding OASIS items where the presence of a physician's order affects the item coding, orders from these allowed practitioners will satisfy the condition of having a physician's order. So for the rest of this presentation, if I say physician's order, it covers a doctor of medicine, MD, doctor of osteopathy, or a DO, doctor of podiatric medicine, or DPM, or podiatrist for short, as well as the advanced practice registered nurse, a clinical nurse specialist, or a physician assistant. Back on slide 8, I mentioned quality episode requirements. This slide explains what you need to know, such as quality episodes are used in the calculation of the quality measures. They are not the same as certification periods. Quality episodes are not the same as the payment periods for the patient-driven grouping model, or PDGM. Quality episodes begin with either a start of care or a resumption of care assessment, the only time points at which they begin. And quality episodes end with a transfer, death at home, or discharge assessment. And another way to think of it is when they are no longer under the agency's care. They've been discharged or transferred for whatever reason. Quality episodes do not use recertification or follow-up or significant change in condition assessments, another follow-up type of assessment, for beginning or ending time points. And a quality episode may span payment periods. If you're a visual learner, this color-coded chart may be helpful. Just remember that a quality episode starts when a patient is admitted or readmitted and ends when they are transferred or discharged for any reason. The quality episode ends once they are no longer in your care. All right, this set of conventions is specific and applies only to the 8 items in Section G, which address the instrumental activities of daily living. When coding these items, report the patient's physical and cognitive ability to perform a task, not the patient's preference or willingness to perform the specified task. Obviously, this requires that they actually go through the motions of the task physically. Do not ask them if they can do it, as they may say yes when they really can't. This is especially true if they live alone. The level of ability refers to the level of assistance, if any, that the patient requires to safely, and I emphasize the word safely, complete a specified task. Assistance may include, as I said earlier, verbal cues, reminders, supervision, and/or standby or hands-on assistance. While the presence or absence of a caregiver may impact the way a patient carries out an activity, it does not impact the assessing clinician's ability to determine and report the level of assistance required for the patient to safely complete the task. If the caregiver is present, they should be able to explain how much assistance they provide during a specific activity if the patient does not know or has cognitive deficits. Understand what tasks are included and which ones are excluded in each item, and select the OASIS response based only on the included tasks. The instructions in the item set will specify exactly what to assess in that particular item. Sorry about that. There were 9 people waiting in the lobby. Let's see here. Where was I? If the patient's ability varies between the different tasks included in a multitask item, report what is true in a majority of the included tasks, giving more weight to tasks that are more frequently performed. Be sure to consider medical restrictions when determining ability. For example, if the ordering physician or allowed practitioner has ordered activity restrictions, remember this when selecting the best response to functional items related to ambulation, transferring, and bathing. I need to pause for just a moment. Hold on. No, here you go. There you go. My cat assistant was demanding to have the window open. Okay, we don't have time. Thanks, Anna. We don't have time to go through all the items, but I do want to point out certain ones that seem to be problematic for some and or are on the newish side. Move 40, patient name, is extremely important to enter correctly. For this, you need to ask to see their official Medicare card, private insurance card, or managed care insurance card. Why, you ask? Because the name on the card is how they are listed in the system. You want the system to be able to match the OASIS to the person in the system. If you put their middle initial in the same field as the first name at the start of care, and then put the initial where it belongs on the next assessment, or vice versa, they won't match, and you'll have two patients listed in IKEYs. Likewise, if you spell their name one way for one assessment and then a different way in a subsequent assessment, the same thing will happen. One of the more frequent requests I receive is to figure out why the patient is listed twice on the roster, and then I have to merge the two patients because their name wasn't entered correctly on one of those assessments. Use caution and pay attention to details. Quality assurance staff should also be looking more closely at everything to ensure that these are accurate. Hoping to fight Medicare beneficiary identity theft, CMS replaced the Social Security number-based health insurance claim number, or HICN, with a new Medicare beneficiary identifier, MBI, beginning 12/31/19, or actually after. So that was on 1/1/2020. They started using the MBI instead of the Social Security number. So you need to review the patient's Medicare card for accuracy, even if the information is in the referral paperwork, because information from discharging facilities frequently includes typographical errors, and you will find this out the hard way. So go the easy route and actually visualize their card. This means you need to request to actually hold the beneficiary's card to verify that the information you're entering into the record is correct. If the patient is a member of a Medicare HMO, another Medicare Advantage plan, or Medicare Part C, enter the Medicare number from their card if available. If they do not have Medicare, mark NA, no Medicare. Do not enter the HMO identification number. Again, do not enter the HMO identification number. Enter the Medicare number if known, whether or not Medicare is the primary payment source for this episode of care. If there are fewer digits than boxes provided, leave boxes at the end blank. And by the way, dash is not a valid response for this item. You either enter the numbers or check NA. And this is all from page 17 of the manual. Excuse me. All right, so you're going to review the patient's Medicaid card or other verifying information if they have Medicaid. And referral information, like I said, may include the number, but again, this should be verified by the clinician physically looking at the card. And you need to make sure that coverage is still in effect also by checking the expiration date on the card, because Medicaid sometimes does have an expiration date. You need to include all digits and letters. And if Medicaid coverage is pending or the patient does not have Medicaid coverage, mark NA, no Medicaid. So again, if it's pending, you're to mark NA, no Medicaid. Regardless of payer source for the home care episode, indicate if the patient has Medicaid by entering the number. And once again, dash is not valid for this item. Several new items were added in 2023 with the change from OASIS-D1 to OASIS-E and are not changing with E1. The 5 items listed here and on the next slide have in common a set of very specific instructions, which I want to emphasize. The first one is if the patient is unable to respond to the question of ethnicity, race, transportation, health literacy, and social isolation, the assessor must document X, patient unable to respond. If the patient is unable to respond to any of these 5 items, a proxy response may be used. That is, a caregiver or advocate who knows how the patient would respond if they were able to may provide the answer, and the clinician would then check all that apply, including X, patient unable to respond. Again, any of these five items, if the patient is unable to respond, the information may be obtained from the medical record, from a proxy, which is basically another source. So the caregiver or the medical record. If the patient declines to respond to any of these 5 items, the assessing clinician must document why, patient declines to respond. The clinician is not to ask the patient's representative or review the patient's history for a response to this item. If the patient declines to respond, you will mark the letter Y, patient declines to respond. Even if the patient's representative answers the question out loud, or you can see it in the paperwork, the clinician is to code it only with Y, patient declines to respond. Item A1010, race, has an additional option the others do not, and that is the letter Z, none of the above. The manual notes that a dash is not a valid response for any of these items, and also points out that they need to be coded at the start of care. This item, M0150, payment sources, is not new, nor has it changed. There have always been 11 pay source options plus UK for unknown. As you can see, the instructions are to check all that apply. And be aware that dash is not a valid response for this item either. It's not valid. If no information is available, select UK unknown. And actually, this item should never be unknown. Your intake coordinator or another staff member should get that information from the referral source at the time the referral is made, so coverage can be verified before the clinician ever meets with the patient. What is changing regarding MU150 is the fact that CMS has lifted the suspension of all payer OASIS submissions. What does this mean for all of you? Beginning on January 1, 2025, home health agencies will need to start getting used to the idea of collecting and submitting OASIS data for all pay sources. That's right. All pay sources will require OASIS to be collected and submitted. From January 1 through June 30th, collection and transmission of the OASIS will be voluntary. However, beginning July 1st of 2025, it will be mandatory. So all agencies need to start planning and preparing for this soon-to-be new reality. Note that the previously excluded individuals, patients with pregnancy-related care, and those under the age of 18 are still excluded from having OASIS collected and transmitted. Those are the new and changed items to which I wanted to draw your attention. Let's move on to the phase after assessment, observation, and data collection. All right, so you've completed all applicable start of care items, and now you have all this data. What to do with it? Where to start? How about at the beginning? First, take a deep breath and then dive in. What was the first thing you noticed when you walked into the patient's house or room? Were there any hazards, such as loose throw rugs, electrical cords stretched across pathways, clutter, or pet waste? How about bugs or a kitchen sink and counter full of dirty dishes? What did you notice about the patient's cognitive status? If the patient answered the door themselves, how was their balance and gait as they led you back to where they wanted you to sit? Is the patient well groomed? Are they wearing clean clothes? Does the patient have multiple diagnoses and comorbidities? Were they just discharged from the hospital with a new diagnosis? Or was it an exacerbation of an existing diagnosis? Is the patient on any new medications? On several medications for which vital signs or weights need to be monitored? Does the patient or their caregiver understand the diagnoses and how to manage the disease processes? Are the patient and caregiver interested and willing to collaborate with you and the rest of the team? Is the patient on oxygen? If so, are there warning signs? All of these areas and more will need to be addressed in the individualized care plan created for each patient. Before we dive into all of that, though, let's review some critical information you must always remember. There are 3 sets of requirements agencies must follow as they admit, care for, and discharge each patient. The first one is the State Operations Manual, also known as the SOM, S-O-M. These are the federal regulations set by the Centers for Medicare and Medicaid Services, or CMS. Excuse me. When your agency applied to become certified by CMS, one of the requirements was to sign a statement promising to follow all CMS rules. Within the SOM, you have the conditions of participation, or COPs, which must be followed. If the COPs are not followed, your agency faces being cited for noncompliance during a survey or complaint investigation if deficiencies are identified. Next, you have the state regulations known as the Nevada Administrative Code, or NAC. And finally, there is the OASIS Guidance Manual, or the manual, which you must always comply with. Regarding the federal and state regulations, remember to check both and follow the most stringent rule that applies to the situation. Each team member, as they carry out the various tasks required for their position, whether it's the director of professional services, field staff, intake coordinator, records clerk, or administrative assistant, etc., must be mindful of this very important information. Speaking of administrative assistant, this is a very important topic that needs clarification. When I call agencies and ask to speak with the administrator, you wouldn't believe how many times the person who comes on the phone is not the administrator, but an administrative assistant. The agency's administrator is responsible for the day-to-day goings-on of the agency. The SOM requires each agency have an alternate administrator, also known as the administrator designee. This person must be approved of and appointed in writing by the administrator and the governing body, and their responsibilities are exactly the same as the administrator. This person must meet the same qualifications as the administrator. So why is this alternate position required? For times when the administrator is out ill, on vacation, or out of state for a conference, whatever the case may be, there must be someone to fill in for the administrator. On the other hand, an administrative assistant, or AA, is someone who works for an executive of some kind, carrying out secretarial tasks like booking appointments, preparing correspondence, scheduling travel and lodging arrangements for the executive. The administrator is an executive of sorts for whom the AA works. An alternate administrator or administrator designee, those are the 2 terms you want to use, is one who actually does the job of the administrator when the administrator is not available. And by the way, in home health, there is no such position as administrator assistant or assistant administrator. All right. The remainder of this presentation focuses on tag G372 in the SOM, which states each patient must receive an individualized written plan of care, which of course includes any necessary revisions while they are under your agency's care. This regulation states that patients are accepted for treatment on the reasonable expectation that a home health agency can meet the patient's medical, nursing, rehabilitative, and social needs in his or her place of residence. What this means is, excuse me, when you receive a referral and you're listening to the referral source tell you what they need, if for whatever reason you cannot meet the need, maybe you don't have enough nurses, you don't have a nurse to go out and do an IV every 8 hours around the clock, or your last physical therapist just broke their leg and they're not available. If the patient needs any of those services and you cannot provide them, you need to give the referral source the name, or, I'm sorry, not the name, but you need to let them know, I'm sorry, we cannot accept this referral at this time. And if you want to give them the reason, that's fine. If you know of another agency that has those services available, you can say, try, this agency or that agency. But you shouldn't accept a patient if you cannot provide what they need. And that covers all of the services that they might need. Then the next thing is each patient must receive an individualized written plan of care, which includes any revisions or additions. What does that mean? Well, after you've prepared the 485 or the plan of care, if a new order comes in, you've got to write it down, or if it was faxed over, or however you receive them nowadays, I guess via electronic fax, maybe. You've got to incorporate that new order into what you're doing for the patient. The SOM continues, the individualized plan of care must specify the care and services necessary to meet the patient-specific needs as identified in the comprehensive assessment, including identification of the responsible disciplines and the measurable outcomes the agency anticipates will occur as a result of implementing and coordinating the plan of care. The individualized plan of care must also specify the patient and caregiver education and training. Services must be furnished in accordance with accepted standards of practice. So what exactly does all this mean? Well, the interpretive guidelines explain that it means, in consideration of the patient's level of acuity, in other words, how sick they are, the agency can effectively and safely provide the patient with the skilled services they need within their home. Keep in mind their home, air quotes, may be in a residential facility for groups, or group home for short. They may live in their adult children's home. It means wherever they call home. So wherever they live or reside, that's their home. Excuse me. On the previous slide, we read that the outcomes established by the clinician together with the patient and caregiver must be measurable. And the plan of care must specify what the clinicians will teach both the patient and or the caregiver, including any applicable hands-on training as needed, say for hand hygiene, glucose level checks, wound care, medication administration, etc. Excuse me. So what we need are SMART goals. You may have heard of this before. SMART goals are specific, measurable, attainable, achievable, actually achievable and or attainable, realistic or relevant, and time-bound. Sorry, my voice is giving out. Hold on. Now, this is just an example for creating SMART goals. Let's say someone says they want to get in shape. Is that a SMART goal? No, but you can remind them that round is a shape. Haha. What is their plan to get into better shape or increase their fitness level? Lose 5 pounds or fit into one less pant size? 5 pounds is measurable. So how would you know if they were on their way? Well, you need a scale to weigh them, or the size of the pair of pants that they want to be able to wear. 5 pounds is probably achievable and realistic enough. And lastly, there needs to be a time or a date by which the goal will be met. Let's say a class reunion, 6 months away. I'm sorry, 6 weeks away. The next question would be how, right? Time to figure out some diet modifications, add some exercise. I forgot I was supposed to be clicking these as I was talking. So there you go. 5 pounds is specific, or one pant size. How are you going to measure it? By documenting their weight every day. Is 5 pounds loss or one pant size down attainable or achievable? Yes. Is this a realistic or relevant goal? Yes. Do you have a time frame by which you want to meet it? Yes, 6 weeks. One scenario that surveyors frequently find is what we call cookie cutter care plans. What do I mean by this? Well, just like these gingerbread men cookies are identical in shape, thanks to an old-fashioned cookie cutter, we see many patients who have identical care plans. I cannot tell you how many times I've seen care plans with 3, 4, 5, even more pages with dozens of orders that are inappropriate for the patient, thanks to the templates and use of copy and paste or whatever software program you're using these days. The problem is, more is not necessarily better, right? I mean, let's face it. What's even worse is the fact that not all the orders are carried out. And a care plan is a set of signed physician orders, right? Can you see the problem here? If all orders are not carried out, the agency will be out of compliance and face a citation for this during your next recertification survey or during a complaint investigation if the surveyor reviews that chart and identifies orders in the care plan that were not carried out. The most important message I want to leave with you today is just say no to cookie cutter care plans. All right. The next thing I want to cover is resumption of care. And this is MU item 32 or M32. The resumption of care date indicates the actual date of the resumption of care visit. Item M102 records the date the physician or allowed practitioner ordered the resumption of care. The date for M102 should be included in the discharge document. And if there is no date, check NA, no specific start of care or resumption of care date ordered. In this case, the start of care or resumption of care must be done within 2 days of the date of discharge unless I'll back up. I didn't write anything here, but I know what to say. You call the patient and they say, oh, can we do it on such and such a date? I have company in town. Well, you've got to look at the referral and figure out, can that wound that's draining profusely wait until 4 days later? In which case you need to tell the patient, no, I'm sorry, according to the referral information, that wound needs to be redressed every day. And they might say, okay. If they absolutely insist on being seen on a certain date that is not within 2 days, you've got to call the doctor and let them know what the conversation was and what the patient said, and whatever the doctor tells you to do, that's what you need to do. So if you have a date that you're told that the orders say the start of care or the resumption of care needs to be done, that's the order that you follow. But if the patient refuses, you have to contact the physician and go from there. The CMS requires that a resumption of care assessment be completed within 2 calendar days after the patient is discharged from the hospital. Remember, this applies only if they were actually admitted and were an inpatient for more than 24 hours for any reason other than diagnostic testing. If they were only there for diagnostic tests or went to the emergency department and were not admitted for care, there is no need to complete a resumption of care. Of course, if there is, wait a second, if there is a rule, there's bound to be an exception or two, right? The first exception is when the ordering practitioner specifies a certain date. It could be less than 2 days. Let's say your patient comes home with an IV access and orders for IV infusions every 8 hours or whatever it might be. A specific time might even be ordered for the start of care visit or the resumption of care visit. The second known exception would be what I already mentioned, is if the patient requests a particular day. And if it's more than 2 days from the DC date, you must contact the ordering practitioner to let them know the patient has requested that the ROC be delayed until whatever the date is they've requested. Depending on the patient's medical condition, the ordering practitioner may or may not agree and may need to communicate directly with the patient and or the caregiver about why the clinician needs to see them before the date they are requesting. Always, always, always be sure to document all details of the circumstances in the medical record, including the date, time, and name of the person with whom you communicated. If the ordering practitioner says the patient's request for a delay is fine, you must write an order to cover yourself and specify the new date for the resumption of care, and you can include in there why it's being delayed and that the ordering practitioner okayed it. Okay, I was asked to explain what, if any, orders are required for a resumption of care. So think about it. This is just an example I made up. Let's say you have a 45-year-old male who lives in a 2-story home with his wife and 3 children, ages 15, 12, and 9. The original primary diagnosis is a non-healing diabetic ulcer. The primary physician ordered skilled nurse 2 times a week for 9 weeks for wound assessment and negative pressure wound therapy, with 4 PRN skilled nursing visits for negative pressure wound therapy dressing issues or machine malfunction. Let's say that between the first and second visit of the 3rd week, the patient was admitted through the emergency department for a cardiac arrest. The spouse called to notify the agency of the patient's admission to the hospital. Excuse me. First thing you would need to do is write an order to hold home health visits effective the day the patient was admitted. You would also need to complete an OASIS transfer item set within 2 days of having been notified by the spouse. 2 days from when you are notified of a transfer, a discharge, or a death, you need to complete the documentation. All right, let's think about this. He had at least one brand new diagnosis, probably some new medications, and maybe even a revised diet. The original skilled nursing frequency orders are no longer valid, so a new order for new frequencies is needed. As I mentioned earlier, excuse me, in the Stone Age, we used a Cardex-like document to plot out how many weeks were left in the certification period and when the visits would be scheduled. I think your software does this all for you now, but you still need to input the days that you're going to be seeing the patients. So you document all specific new details related to the new diagnoses, medications, diet, activity restrictions, if any, new skilled nursing frequency, maybe a PTOT evaluation is warranted. The skilled nurse sees that when she goes out, and so she adds that to the new order. Is the negative pressure wound therapy still being used? What's the latest on that? Do we need revised orders for that? Do we need a change in the PRN orders? And remember, anytime you write a PRN order and you write the frequency, like skilled nursing visits 3 times a week for 2 weeks and PRN, you've got to put PRN what? PRN wound dressing issues or PRN catheter clogged or whatever the case may be. You have to put a reason for the PRN visit. You can't just say PRN, whatever. All right, we've come to the summary slide. And again, I apologize for all the delays and everything. I still need to send you the post-test and evaluation, or we could just skip that part. You wouldn't get any CEUs for today's session. I'll do the second part next month sometime. Let's see. I see a bunch of hands raised. Let me see if I can lower them all. No. Well, what I'm going to do is open it for questions. Oops. Excuse me. I am going to unmute everyone. And if there's noise going on in your background, please mute yourself. If you want to speak, you can raise your hand. I will unmute you. I think. So A from assured. I'm not sure if you guys can see the same screen I do. I've lowered your hand and I've opened your mic. I guess I'll just lower everybody's hand. And then if you still have a question, put your hand back up. Jeanette Serrano has a question. Is that right? Let me see if I can unmute you. Hold on. So I unmuted you. Are you muted on your end? So I'm just checking the chat. All right, I apologize. I am unmuting all of you, but I don't hear anything. Oh, Ashley McKeever is asking, is there a list of diagnostic tests accepted in the handbook somewhere? For example, I had a patient that was never admitted to the floor, though admitted to the hospital for blood transfusion. He stayed in the ER until his blood panels came back within range and then was discharged. Would this be considered a diagnostic test for an admission? I treated it as an admission. I hear somebody. I hear somebody moving something around on their desk. Let me see. Never admitted. Well, if you had orders to admit them, you would admit them, but are you talking about a resumption of care or an admission, Ashley? Because that would make a difference. If the practitioner ordered home health for whatever, you wouldn't be doing a resumption of care, so it wouldn't matter if they were in for tests or not. It's a referral from the physician to see the patient, regardless of if they were admitted or not. If that makes sense. Oh, it would have been for a resumption of care. Okay. I will have to get back to you on that because that's a new one. I've never heard that situation. Okay, an existing patient. Yeah. I will look into that. Let me record this question. Not that one. Come on, mouse, work with me. Does anybody else have a question? I can hear somebody, but I don't hear anybody talking. I just hear noises. Okay, Ariel. Excuse me. If I hadn't had such a huge computer snafu this morning, I was planning to send you an email with the attachments, with links included on how to access the documents that I mentioned during the presentation. So after we sign off today, I will get that to everyone with the links to everything that you need. And again, I apologize for the technological difficulties. There's just no way around it until I get my new computer. Yeah. So let's see. Oh, you're welcome. So, if you have questions, this is my contact information. I'm here Monday through Friday, 8 a.m. to 4:30 p.m. Here are links to all the resources if you want to check them out before I get that email to you with the same links. These are the links I would be sending you in the email. So in the resources, I think there's 4 slides in today's handout. There's all kinds of links to information, and I highly recommend that you check them out. So are there any other questions? Because we're not going to be able to do the post test today. I apologize. It's just so frustrating for me. You have no idea. I don't see any more questions in the chat. If you have any more questions, please type them in. Otherwise, I will be ending this session. FCHC May, you have your hand up. Let me see if I can unmute you. I did unmute you. I don't know if you'll be able to try speaking. Okay, well, if you have a question, put it in the chat box, please.
Okay. Yeah.
Oh, I can hear you now. Okay, I hear you.
Yeah.
Yep.
What's the limitation of the use of telemedicine for providers like APRNs, doctors, just doing telemed for or visiting patients for or giving orders for home health services? Are there?
Okay, I missed the first part, but let me just see if I let me see if I understand what you're saying. You're asking if a practitioner who's giving you orders to go see a patient did their visit via telemed, or are you asking if you can do your visits using telemed?
No, the practitioners who are just doing telemed and ordering it for admission to home health.
That's all they're doing? They're not actually seeing them in person?
No, some are not. What is the limitation? Are there any limitations for that, ma'am? Because
I'd have to look into it because I don't think there are, but that's kind of that I don't think that would be under my jurisdiction, but I will look into it. Give me just a moment. Let me write it down here.
Okay.
Okay, so the question is, can you accept orders from a practitioner who only saw the patient via telemed and not in person?
Right. Yes, ma'am.
Okay. Have they ever seen them in person?
Before maybe the previous 2 months, 3 months, 2 months ago or 3 months ago.
Okay, hold on. Can I get an idea of what the diagnoses were or why they needed home health?
Well, they have some diabetes. No, like hypertension, diabetes, COPD. Yeah, COPD.
So the COVID PHE is over. Why are they still seeing them via telemed?
Yeah. I don't know. So COVID monitoring.
Do they live in a rural area? Is that why they had to do it by telemed?
No. No. We don't know. No. Still here. No, that's why we told the doctor you need to see the patient.
Yeah, and when was the face-to-face done? Because that can't be done via telemed.
That's what we are asking them to. Because they have face-to-face and yet you're doing it through telemed.
No, they need to give them an exam, listen to their heart, lungs, blah, 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 all that.
Yeah.
Yeah.
That's it. Okay.
So there's your answer.
So they need to so they need to have a face-to-face, a physical. Yeah, that's why we explained to the doctors. What they answer us on this.
Yep.
Oh, Medicare paid us. I mean, so.
Thank you for the question.
What else? How about the COVID monitoring for employees, ma'am? Are still, do we have to put it in the system? Like,
what does your agency policy say? Because listen to me. Hold on, listen. The PHE was declared to be over on May 11th of 2023. And while I know that, hold on.
Because it's still in the system automatic.
Yeah, that's why we want to know, Mom, because we didn't receive any memo that we'll stop that in the system.
Yes, you received a memo indicating that the PHE was declared to be over.
Yes. Oh, okay. Yeah, we did that. We got that, but not the one in the system that we have to remove it or yeah.
Well, what system are you using? Are you talking about your software? Because I don't have any control over that.
Yeah, it's our software.
The agencies have to talk to the vendor. You have to talk to the vendor to tell them what it needs to be, and then your policy needs to direct that as well.
Okay, we'll do that.
Thank you.
All right. Thank you for the question. Anyone
Everything
else?
No, we can just file this effective today or whatever.
Romeo, you're late. We're just getting ready to sign off. Okay, if nobody has any more questions, then I am going to end this meeting and I will talk to you soon. Take care, everyone. Bye-bye.